Good morning, everyone. Welcome back to the second part of this session. As you know, today's session is focused on equity and access to living donor kidney transplantation. So I'll introduce myself. My name is Sunita Singh. I'm the medical director of the UHN Living Kidney Donation Program. And I'm also a transplant nephrologist here at UHN. I'll be moderating today's session. Before we start, I just want to remind everyone that you can submit your questions for today's session on slido.com. Please use the event code #AM1B. And we also are recording today's session live on YouTube on the Center for Living Organ Donations channel. So you'll be able to check out the session there. And for those who tuned in a little bit earlier today, you heard about international perspectives on access and equity to living donor kidney transplantation. So today's session is really focused on improving access to living donor kidney transplantation in the Canadian context. And we have a terrific lineup of speakers specifically to talk about this today. A lot of what you'll hear today also stems from the ACTION project, which is a collaboration between the Center for Living Organ Donation here at UHN, as well as the Providence Health Research Institute in BC. And this is led by Dr. Ishvan Mucci from UHN, Dr. Jag Gill from BC, both of which you'll be hearing from today. And the aim of this project is really to reduce inequities in access to living kidney donation and transplantation in the South Asian communities, as well as the Black and Caribbean communities in Canada. So we'll be able to hear from those really at the forefront of research in this field in Canada, but are also very fortunate to hear from several patients, donors, and recipients to really share their stories and their lived experiences with living donor kidney transplantation in Canada. I'm going to introduce the panelists as we go through the talk, but we're very thankful and happy to have our patient partners, Rima Garcha, as well as Fadia Jerome-Smith and Winnie Jerome. And then we've got numerous experts in the field of access and equity in living donor kidney transplantation to speak to us today, including Dr. Jag Gill, Dr. Ishvan Mucci, Noor El-Dasuki, as well as Lydia Joy Marshall. So welcome, everyone. Thank you for joining us. And before we start, I just want to turn it over to Dr. Atul Kumar, who is the director of the Ajmera Transplant Center here at UHN. And I'll turn it over to him to welcome us and to kick off this session.
Thank you, Sunita. So welcome, everybody. And I'm really excited to launch earlier today and now ongoing this very exciting week focused on living donation and both kidney and liver living donation. It's going to prove to be, I think, a very, very interesting number of sessions. I want to specifically thank all our external speakers and our internal speakers who have contributed to this, as well as our many patient partners who have contributed to this. I also want to give a special shout out to Paula Neves and the whole group from the Center for Living Donation, who really spent an incredible amount of time organizing this in the midst of a pandemic. So I hope you'll all enjoy, and I hope you'll attend many different sessions throughout the week, and I hope we get lots of questions and comments. So I will turn it back over to you, Sunita. Thank you.
Great, thanks, Dr. Kumar. So we're going to kick it off with our patient partner. Rima Garcha has a pre-recorded video for us, but she is present on the call for Q&A. So if there's any questions that you have for Rima, she is here to answer them. So without further ado, here is Rima's story.
Everyone, my name is Rima, and proud to say that I'm a living kidney donor. My journey started several years ago when my sister battled with kidney disease for most of her life. I always knew that I would be, called to the plate, so to speak, and to be able to help her, but just never knew when or how. And it was a very difficult time for my sister to be able to ask family and friends to have this part of a person to be able to donate that to them. But I tried to put my sister at ease. I remember saying to her, "Don't worry, sis, my kidney's your kidney," type of thing. And I was fortunate enough to go through the process of from the questionnaire to all the tests. It was myself, my brother, and my mom that actually had the same blood type. So there was the three of us that sort of started that process at the same time here in British Columbia. And I was the lucky one. I was the chosen one. I often say when I got that call, I felt like I won the lottery. It was just a fantastic relief that at least that I was the best match from a family donation perspective. And you know, we underwent it. So I was able to donate my kidney to her in February of 2018. Proud to say that she's doing great, and I'm also doing wonderful. I know, you know, now looking back, I mean, this whole process has given me so much purpose in life, and in words that I can't even really describe. You know, was I scared? I wasn't really scared of undergoing surgery or anything like that. I was more scared of the potential outcome if things didn't go right. You know, for my sister mostly, and you know, so that was my biggest fear, is what if we went through this and things didn't turn out the way that we wanted them to. My family was all quite supportive. My daughter, she was 8 at the time. She was more outwardly, I guess you could say, you know, scared. And I reassured her. I said, listen, I said, I've got an opportunity to save my sister's life. And, you know, she was young at the time, so she, you know, took a little bit of comfort in understanding that, and I took some time with her. But at the end of the day, I was fortunate that my entire family was very supportive of this process and of this journey that my sister and that the entire family has been on. I do realize, though, that within the South Asian community, that there are potential barriers to living kidney donation, and I would say that you know, they could range from communication barriers to cultural issues, perhaps maybe generational issues in terms of perspectives. So I would just, you know, continue to ensure that stories like mine and my sister's are out there, that can be you know, that can be heard and understood with, like I said, the sense of purpose that I've received in my life, and everyone around me as well. My entire family has felt this, and this incredible gift. Not only is it a gift to my sister, but it's also a gift to all of us that have been a part of this journey. So if there's anything that I can do, is to continue to spread our story and try to help with some of those cultural issues that may be out there. And I'm happy to do that. Thank you.
Thank you very much, Rima, for sharing that story. As I mentioned before, we'll have the opportunity to ask Rima questions in the Q&A. Next, I'd like to introduce Dr. Jag Gill. He will be our next speaker. And Dr. Gill is an associate professor of medicine at UBC. He's also the medical director of the transplant program at St. Paul's Hospital. Dr. Gill is a CHR-funded investigator, and his research interests are really focused on transplant tourism, transplant opportunities for the elderly, as well as increasing access and equity to living donor kidney transplantation for marginalized communities. So Dr. Gill, looking forward to your talk.
Thanks very much, Sunita. Thanks, Rima, and thanks to the organizers for the opportunity to present here today. I think This has been a great opportunity to kind of just share best practices in terms of what's been going on. What I'm going to talk about a little bit today is some of the experiences we've got in terms of Canada. And so the action project, which Sunita had introduced, is something that has been born of a lot of kind of hard work at both UHN and in BC here. And so we're keen to kind of give you a bit of an outlook of what things look like here. Just going to try to advance my slides here. There we go. So what I'll go through is just very briefly kind of where we are in Canada in terms of the epidemiologic recognition of health inequities, and kind of where we've where we've landed and where we need to go from that perspective, and talk a bit about how we move forward from that standpoint, and then sum up by talking about the action project itself. So as those of you that were part of the session earlier today clearly have heard that health-related disparities are not unique to one community. This is something that we've seen across the board internationally as well as in Canada, not just in kidney disease and organ donation, but certainly across the board. And so it's something that is key to have us address in our community. If we look at the data within Canada, there's been a number of epidemiologic reports that have looked at the prevalence of kidney disease in and of itself. And so the disease burden is higher in a number of populations based on sociodemographic characteristics. This is some data that's outlined from CIHI that's kind of looked at, it's dated a little bit, and you'll notice that trend with some of the epidemiologic data is that it's been a while since there's been a close look at this stuff. But you can see that obviously Aboriginal or Indigenous communities have a higher incidence of a higher prevalence of kidney disease across gender groups, and similar trends are seen in many other subgroups. And so in the South Asian community, and among the East Asian community, among the African community, and amongst, layering on top of that, socioeconomic status is another big factor that also is associated with an increased prevalence of kidney disease. Now, if we look at transplantation and what's been described, again, we have to kind of comb the literature and go back a little bit, but there's been some nice analyses that were conducted using Canadian data. And this is by Dr. Yates and colleagues, and this was looking at the using core data and trying to look at the relative incidence of kidney transplantation broken down by deceased and living donor among Black Canadians relative to white Canadians. And as you can see, Black Canadians are about 40% less likely to undergo transplantation as a whole, but that disparity is certainly more marked when we look at living donor transplantation. So about a 65% less likely to undergo living donor kidney transplantation. If we look at other populations, very similar trends were borne out. And so if you look at what's described here as Indo-Asians or South Asians, in a similar type of analysis using core data, it was found that there were 31% less likely to undergo kidney transplantation. East Asians were found to be about 29% less likely to undergo kidney transplantation. If we look at living donor transplantation, again, that same pattern seems to be borne out, where the disparity seems to be exaggerated, where Indo-Asians are about 58% less likely to undergo living donor transplantation, and East Asians about 70% less likely. So certainly some strong trends noticed in there. Now, a lot of that data is from a while ago, and there has been little data that's been since that time, actually, that's really looked at the experience. So the first question is, do these trends persist today, or have we moved the needle at all in this? And this is an analysis that was done in Ontario by Dr. Mucci and Dr. Kim and colleagues there, trying to replicate again, looking at the incidence of the likelihood of getting a living donor kidney transplant by ethnicity. And again, I'll just direct you to the table on the bottom here. And if you look in the different subgroups here of African Canadian, East Asian, and South Asian, again, we're seeing that there's a significantly reduced odds of getting a living donor kidney transplant, again, along the same lines, right? About 70% less likely. And so this was a slightly more recent cohort. And so it appears that those trends continue to persist. On a national level, there hasn't been a very close look at this, but if we look in general, what's happened in living donation, as we all appreciate, living donation's been pretty flat in this country. If we go back, 10 some odd years, we've been sitting at around the same number of living donor transplants per year in Canada for quite a while now. Now, if we look to the United States, where there's been a retraction in living donation, we haven't seen that to the same extent yet in Canada, but it is still cause for pause when we see that there's a leveling off of living donation rates, even when we've had a number of initiatives during that time period, whether it's kidney paired donation, whether it's trying to work with incompatibility. And despite that, we've kind of had a bit of a leveling. If we look at what's happened in terms of the relative incidence, this is just, again, excludes Quebec, the table there. But basically, if you look at the relative incidence of living donation, which is a slightly different way to look at it, we're not looking at transplant rates, but donation, but really gets you to the same point where you're seeing a very similar disparity where non-Caucasian communities, and here we've got Black, South Asian, and East Asian, are about 60 some odd % less likely to have living kidney donation occur. And so these are cause for concern and do suggest that these trends are not changing and that these trends do persist today. So the big question is, we've had years of really presenting this epidemiological data, and that's something that we do often, and we talk about this issue. And where we tend to get stuck, it appears, is next steps, right? So we've noticed these observations, we know they exist, we appreciate that they're not changing, but we haven't really, as a community, been able to move beyond that and say, well, how do we actually, take the next step? And so why is that? And I think part of it is that it's not a simple fix, right? It's a multi-pronged issue. We have to go a long way to really understand some of the drivers behind this. But if we kind of take a step back and think about what we need to really do, I mean, some of it is, intuitive, but obviously we have to look beyond the individual, and we have to start in our care and in our day-to-day kind of practice, start thinking about the social determinants of health and how that kind of weighs into the interactions we're having with our patients, both on the patient side and on ours. But when we see a patient, we got to think more about what the different aspects are in their life that may be contributing to their ability to access care, their understanding of what's going on, our ability to deliver the care in the manner that it needs to be delivered. All those issues kind of need to be considered. We also need to, quite frankly, acknowledge the role of the healthcare system in contributing to these inequities. And so I like to think we're all very well intentioned in our work, and we want to do the best for everybody, but the system does have flaws in it. And I think we can all appreciate that. And so this notion of, one size fits all doesn't work. And I think we all kind of intuitively know that, but putting that into practice is sometimes challenging when we've got, algorithms and policies and issues in place in each of our respective centers. And so I think that critically evaluating our current model of care is an important first step for us to kind of really think how we can at least start to move the needle on this area. And then specifically, when we're talking about, groups that are marginalized by race or ethnicity, we got to think about what's the cultural sensitivity in our interactions and in terms of our processes, or the cultural safety, and how do we try to move on that and improve that process. We also need to appreciate that some of these factors are modifiable. So if we look at some of the data, if we look at some of the assumptions that may come from that, it's often that once something, I put cultural in quotation marks there, because sometimes once something gets driven or labeled as a cultural barrier, there's a tendency to think that may not be modifiable. And I think that we need to, there's been examples of that, I'm sure, as you heard this morning, that there are opportunities to modify what's happening in terms of access within cultural groups. It also oversimplifies the issue, because within a cultural group, you've got a ton of diversity and tons of issues that need to be considered. And so I think appreciating that there are modifiable things that we can look at, particularly within our health systems, that's an important step to move us forward. An example of that, this is just a study, this is a simple epidemiological analysis that we had done years ago, but it just kind of shows you how simple look at things in a slightly different way can sometimes change the narrative a bit. And so, as we know, in the United States, living kidney donation or access to living donor transplantation is reduced among African Americans. The presumption has always been that living donation, the lack of living donors is a driver of that, which is likely true to some extent. But we had done this analysis where we had simply looked at this interaction between median household income and race and reported living donation rates after adjusting for various factors, including the incidence of end-stage renal disease in that population and those kinds of issues. And what we actually found is that really you start to see that when you break things down by socioeconomic status, the differences start to dissipate. And so within each category of income group that's laid out here between Q1 to Q5, and you go kind of from the lowest income group to the highest, what you tend to see is that, in fact, you don't see a huge difference. And if anything, you see the difference. The living donation rates were higher in African Americans when you get to the high income groups. Now, a larger proportion of the African American population was within the lower SES subgroup, which is why we see lower overall rates. But it does go to say that perhaps financial barriers and some modifiable factors that we could address in terms of that aspect of it may be useful in trying to reduce some of the disparities that we're seeing in access to transplantation in the US. And so how do we kind of move forward? Well, I think, as I said earlier, it's complicated, and it's partly complicated because the more people that need to be involved and the more engagement that's required, the harder it is to get things done. And that's kind of an essential piece to this work. And so you have to make sure every stakeholder is engaged at a very early phase before we do this. And so institutions, clinicians, but also government and policymakers. So depending on who's going to actually implement the change, we may have a great study that says this works, but you kind of need partners up front to say we need to move this field forward, and how are we going to actually implement those changes so they're sustainable. And of course, most importantly, we need patients and also community partners, and community members need to be a key part of the process so that we can really make sure that the change that's being implemented is not a top-down kind of approach. It is much more collaborative in nature. Now, some kind of key considerations or challenges as we kind of look at this work. First of all, I think when we talk about work, we have a tendency, and some of this is pragmatic, right? We have to lump groups together. We have to say South Asian. We have to say, East Asian. We have to kind of say Indigenous and lump a fairly diverse population into one lump. And I think that makes it challenging, but we need to be mindful of that throughout the entire time. And so there's a significant amount of diversity within each target population that we're looking at. And then on top of that, we got to think about the geographical considerations. And so if we're looking at health services interventions, obviously there's generic things that we could do that could help, but the specifics when we're looking at the difference in the target populations can vary quite significantly, whether we're talking about Vancouver versus Winnipeg versus Toronto. And so the generalizability can be a bit limited when we're doing some of this work. The other thing that's important from a research standpoint is mixed methods are often required. So I'm primarily a quantitative researcher. So quantitative methods will only get you so far in this area. You need qualitative input. You need some in-depth feedback on where we're heading, and then we can weave that into some sort of a measurable quantitative study thereafter. Funding opportunities are certainly improving, and I'm thankful to the organizations that have given us some funding to lead this work. But traditionally, that's been a challenge and a barrier to kind of try to get some of this work addressed. And as I said earlier, partnerships are key, and not just the partnerships I mentioned earlier, but I think as a country, it's important that, that we're not a huge country. And so people that are interested in this area, people that are working in this area, it's been important to come together. And so the collaboration between UHN and UBC has been important in terms of driving some of this work and really making it happen. So I'll talk a bit about the ACTION project. The formal name of the project is Improving Access to Living Donor Kidney Transplantation in Ethno-Racial Minority Communities in Canada. And Dr. Singh kindly gave a bit of a brief introduction to this, but I'll just talk you through a little bit more of the specific initiatives that are embedded within this. And so our overarching goal, as you heard, really was to aim towards equitable access to living donor transplantation, irrespective of race or ethnicity. And so the goal here is to focus on living donor transplantation as a first phase of this work, and really look at some few target communities to really try to address this issue. Now, the specific goals of this project and our aim really was to as I said earlier, the geographic considerations, the target population considerations are variable. And so when we thought about putting this together, the thought was to apply a standardized approach. So if our goal here is we will provide a framework of how to address this issue, or how we think we could address this issue. And we could apply that and develop that in 2 different provinces that have different considerations, and in 2 different target populations that are based on the demographic considerations within each of those provinces. And so that's what we did. And the process that we're embarking on, or have embarked on, is to engage patients and community members right at the outset, as part of developing the program, as well as gaining the data and have a better understanding of what the barriers are to living donor transplantation, so that we can kind of move forward and develop solutions in partnership. Leading from that would be a series of interventions that would, from a health services perspective, but also from a community perspective, that could then be evaluated and implemented. And we develop and lay out those plans and pilot some of that in each of our provinces and our target population. And the hope is that through this, what we have nationally is a bit of a template, as I said earlier, to say, okay, well, if the same basic bones can be used to apply this kind of approach in 2 provinces, then that should be applied in other communities. And so, we've started with a few key target populations, but the intent here really is to have a much broader study that's going to go to spread throughout the country in other regions as well. Another important part of this was to update the epidemiological data that we have. And so, as I showed you earlier, much of the data is, over 10 years old now, in terms of looking with, save a few studies that have been done within individual provinces. But from a national perspective, as many of you appreciate, there's certainly this is an important time in terms of data in our field in Canada. We're on the kind of precipice of building a national data system that hopefully will be something that can lead us forward. And so I think it's timely now for us to kind of work and create some new data on this issue, and also work with our patient partners and with our community partners to understand how best that data should be captured, how best that data should be evaluated, and how it should be reported. And so moving forward, we'd like to inform measures to track and report some of these inequities, and also our successes as we move forward in the field. So these were the target populations in the 2 provinces, as I've said. So in BC, we've targeted the South Asian population, and in Ontario, the target population has been the African, Caribbean, and Black community. This was based, as I said, on some of the work that's been done in the past in our respective provinces, and also the population demographics that exist in those areas. And so we thought this was a reasonable approach to begin. But as I say, the hope is to really branch this out to other communities. And I'll talk a bit about some of the background piece in BC in terms of the landscape and how we kind of came to be. So as I had said, there's obviously different considerations in each province in terms of where we're starting from. And so in BC, there's a few unique things that we do. So one is there's a provincial approach to both renal care and transplantation care. And so, we've got the BC Renal Agency, which coordinates and funds a lot of the work that's done on the general nephrology side, including some standardized algorithms of care, standardized funding streams for chronic kidney disease clinics and so on and so forth. And that offers us an opportunity to really tap into a bit of a standardized system to do some implementation work there. On the transplantation side, we're also provincially organized. And so we've got 2 transplant programs based in Vancouver. Those are both sitting in Vancouver, but we do serve the entire province. And so we have a provincial mandate, and that's facilitated by BC Transplant, which is our funding body. And that again allows us to standardize some things province-wide and in a rather quick fashion. We've also had a bit of a history of a culture of living donation in this province, and that's been fortunate for our patient population that have had improved access to living donor transplantation as a result. And so that's the figure on the right, simply just looking at the data from our annual report at BC Transplant. And as you can see, the living donor rate per million population is generally hovered between 20 to 25 over the years, and that's higher than the national average by a decent margin. And so that can springboard us, we hope, to additional initiatives. The other key piece, there's been a few big initiatives that we've been undertaking in recent years to try to expand living donation further, and really with a focus around preemptive living donor transplantation. And so I just wanted to take a few moments to outline a couple of those because they do dovetail importantly with this initiative. The Transplant First initiative is something that we've undertaken in partnership with BC Transplant and BC Renal Agency. And that's very much the mandate there is to target chronic kidney disease clinics around the province. And the idea being that we've got a new clinical pathway there that really divorces this idea of dialysis from kidney transplantation. And so kidney transplantation is considered at an earlier stage in the disease process. Active work to try to identify potential living donors and work towards that area has been something that's been key there, and an important level of education. So that's an ongoing initiative in the background that is provincial in scope and is continuing to evolve. That's happening here. The other important initiative in play is the Bridge study, and so this is a project I'm leading that's funded by CIHR's SPORE program, and we were fortunate to kind of develop this. And so it's very similar in principle to what we're doing here. So basically, it's looking at access to living donor transplantation in Indigenous populations in our province. I'll be speaking about this in a bit more detail on a session on Friday, so I won't get into that too much right now. But basically, the premise was similar. When we started that project, the disparities are stark in that community. And so the thought in our province was to use this funding opportunity that we had to develop a bit of a standardized approach where we will use qualitative data and quantitative data to gather the feedback, partner with patients, partner with elders, partner with communities, so that we can actually develop a bit of an algorithm and in terms of our clinical care pathways. And that's been the key, right, with that project. The real focus has been on, yes, there's community-based interventions that are required, but from a health services perspective, in terms of how we're delivering the education, that's something we could control and modify. And so let's really focus in on that piece. And when this opportunity for action came along, really, I think when we had discussed this at a very early stage, the thought is to apply that type of a model to other populations here. So it is, working towards what I said earlier, kind of developing a template and then generalizing that to other subpopulations in other regions. And that's how we're moving forward. And then, of course, as many of you appreciate, we do have a large South Asian patient population. And when we've looked at the demographics of our South Asian population in BC, it is predominantly, although not exclusively, it's still diverse in terms of the population, but there is a larger subset of North Indian, Punjabi-speaking individuals. And so a lot of our work has been focused on that subgroup as an initial phase here. So some background data that we also had in BC leading into this, we had done some survey work with end-stage renal disease patients in British Columbia, trying to get their sense of, what's their willingness to discuss living donor transplantation, what's their approach or perspective, how willing are they to talk to prospective donors in terms of living donation. And not surprisingly, Noor is going to present after me and present some of the similar data that's been accrued in Ontario. But really, I think a similar message has emerged, which is there is certainly a lower willingness among some groups, in South Asians and East Asians, is what we found, that had a lower willingness to discuss the need for living donor transplantation. But importantly, and the figure in the bottom, don't bother trying to work your way through it, but basically what that's looking at is we presented a series of scenarios and said, okay, what if we did this? And what if you felt confident that your donor is actually engaged in this process, or you were the risk and benefits were better explained, and if we gave you more education and all that? Clearly it's modifiable, right? So that point I made earlier to say something's cultural and therefore not modifiable is obviously a fallacy. And so there is certainly a significant, over 40% of people would modify their thinking around approaching and accessing living donation if under certain conditions were met or certain information was provided. Sorry, there we go. Oops. So the key elements really of the project, then, as I've outlined, and just want to give you an update on where we're at right now. And so we're just, under a year into this, and obviously truncated by COVID, which is, for all of our work thrown a wrench into everything. But we're working on updating the Canadian epidemiologic analyses, and so I've been working with CORE and CIHI, and we're replicating some of the analyses that were done in the past. But more importantly, we're working we're on kind of looking at all the data holdings within CIHI to merge some of those data and have linkages so that we can get some new data and look at some more nuanced analyses with this. And that's been a bit of a challenge, quite frankly, simply because of the degree of missingness that occurs in terms of ethnicity and race variables. And so we're working to try to supplement that so that we can actually do some of these analyses. But I think there's going to be some important work there in terms of, as I say, not just producing the new data, but also identifying the gaps in the data and where we need to move forward from a data perspective in terms of this. In terms of the core project itself, a lot of the work that's being done in both provinces in the last year have been around engagement of community and patients, building on the relationships that already existed, but then actually expanding that to include new groups. In British Columbia, there wasn't the same degree of network in terms of kidney disease and health with the South Asian community. So we put a lot of work, and I really commend our community engagement partners, who I'll outline in the last slide here, to really do a lot of this work and bring together a group of individuals that are keen to kind of move forward and help us plan this project. We've engaged with policymakers and funders already in our province so that they know this is coming, they know this is happening, and we've already worked with the individuals on the other projects that are ongoing in the Transplant First initiative so that this can be kind of melded in as part of that depending on our findings from this. And then the bulk has really been around trying to collect some of the core data through these partnerships with the individuals. I just wanted to identify some of the partners. This is not an exhaustive list of partners, but PICS, or the Progressive Intercultural Services in Surrey, British Columbia, has been one of our major key partner organizations. There's a number of other ones listed there. There's also, you'll notice, not just organizations restricted to British Columbia, but we wanted to leverage the work that's been done, the hard work that's been done in Ontario by the UHN group in developing some relationships with the South Asian community in Ontario. And so we're working with those individuals as well, and those groups as well. And that's really been a great experience. In terms of where we are, in terms of the recipient and donor data, Noor is going to review kind of some of the preliminary data we have, but to date, really what's happened is a lot of qualitative work's been done. So in-depth interviews with donors, previous donors, transplant recipients, both who had a living donor transplant and transplant recipients who were unsuccessful in achieving a living donor transplant have been conducted. And the types of data and kind of that we've acquired there, and the conversations have been around understanding their South Asian identity, their thoughts on that, and really been a good chunk has been focused on what's been their experiences through healthcare, specifically through the kidney transplant experience, feedback on specific elements of the clinical pathway that we deliver to see if there's areas that were lacking and how we could modify that from a culturally tailored perspective. And also, of course, a broader sense of what the barriers have been to accessing living donor transplantation for the recipients, and considering donation and perhaps going through the process of donation among the potential donors. We've also obtained broad community perceptions in terms of what about living donation and transplantation and where that sits. And there's been some interesting data largely around communication, around community engagement. And one message we've heard very clearly is that certainly the clinical pathway needs to be modified, but we also need to start thinking about how we're going to engage with the community on a longitudinal basis to make sure there's very targeted educational events that are occurring there. But I'll leave that to Noor to discuss some of the highlights of that in the next talk. In terms of next steps, we're currently in the process of evaluating that data in a more detailed manner. We've got a group of an advisory council in British Columbia that we'll be reviewing the data with, as well, going back to community leaders and conducting some focus groups to round out our potential proposals for what the interventions would be. And the interventions are really targeted in two streams, right? So clearly from a clinical pathways perspective, there's going to be some changes that we can make, whether it's new educational tools, whether it's more navigators, that's yet to be determined based on the data. But that's one aspect of it. And then the other aspect is going to be more a broad-based, community-based interventions that would supplement the work that's being done in the programs to address some of these disparities. And then we'd be developing a pilot to pilot some of these interventions, and then a longitudinal kind of evaluation and implementation strategy around that. So I just wanted to end by thanking all the individuals that have come together for this work in a very short period of time, so I really do appreciate these individuals coming forward. And I have to say, you know, all of us have been through a tough time through COVID, and all of us have been kind of learned how to adapt. And I personally have been very impressed by all the individuals here that have kind of really not missed a beat in terms of their commitment to this project and their engagement in this work. And so I've listed, you've met Rima, who's one of our patient partners, but also the other patient partners, Jesse, Gil, Renita Singh, Dale Bad, and Gurbinder Bad, are all individuals that we're working with. From a community engagement perspective, I'd like to certainly highlight that. That's been a significant work that's done by Ratinder, who's been our community engagement specialist, as well as Raj Handel from PICS, who's been really helpful in terms of this. We've got a fantastic advisory council made up of physicians, made up of nephrologists, made up of community members, patients that are really helpful. And then, of course, none of this is possible without our project management team led by Jamie Schick, and our qualitative team outlined below. So I'll stop there, Sunita, and thank you very much for your attention.
Great, thanks very much, Jack. That was a terrific overview of the Action Project and where things stand. It's a really exciting project, and I think it'll be really great to hear Noor talk about some of the early data coming out of that initiative, as well as some of the barriers. Next to speak on that is Noor Al-Dasuki. Noor Al-Dasuki is a research associate with the Kidney Health, Kidney Health and Education and Research Group at the University Health Network. She does have a background in biomedical science, and she actually has completed a Master of Science in Global Health from McMaster. She works within the UHN group, managing various kidney health and education and research projects, and she works with marginalized communities to improve equitable access to living organ donation. So it'd be great to hear from Noor on some of the early data. So Noor, over to you.
Hi, everyone. Thank you, Dr. Singh, for that introduction. Can you hear me okay? Okay. So as was mentioned, I am a research associate with the Kidney Health Education and Research Group, and not a telemarketer, as one might think with this headset. So today I'll be building off of Dr. Gill's presentation and talking a little bit about some of the barriers to living donor kidney transplant in South Asian communities across the country that we've identified as part of the Action Project. Before we start, I just wanted to mention that I don't have any conflicts of interest to disclose, but I do just want to note that this presentation provides a research perspective on the topic and not a community perspective. All right, so I just wanted to start with a brief introduction to the community. So South Asian communities actually represent about 6% of the country's population, according to the 2016 census. The South Asian community is actually very diverse, which is why I try to use the terminology of communities. Although the majority of South Asian Canadians are first generation, there is also a growing proportion of second and third generation individuals who have ancestral origins in India, Pakistan, Sri Lanka, Bangladesh, and many other countries as well. And as Dr. Gill mentioned, research across the country has shown that South Asian patients experience inequitable access to living donor kidney transplant. And I think now that we kind of have identified the disparity, we have a responsibility to act on it and to understand why that is. So our team has undertaken research as part of the Action Project to understand the barriers that South Asian patients experience in accessing living donor kidney transplant. And I'm going to go over some of those findings with you now. So I'm going to start off with some of the research that was done in Ontario. As Dr. Gill mentioned, we've had some research done in Ontario and some in British Columbia. So in Ontario, over the last 5 years, actually, we've asked adult patients who were potential kidney transplant candidates across the Greater Toronto Area to complete an electronic survey on their knowledge about and their readiness to pursue living donation. It's important to note that these questionnaires were only available in English, so we were unfortunately not able to engage patients who couldn't read English at a grade 5 level or higher, which is an important limitation of this work. And these findings might also not necessarily be applicable to South Asian communities outside of the Greater Toronto Area. But within those considerations, we did have 18% of participants who participated in our study identified as South Asian, and a majority of those were male and had at least a high school education. So we asked patients if they would be willing to accept an offer of living donation and found that South Asian patients were as likely as other groups to say yes. However, when we asked patients if they've talked to others about their interest in living donation, only a quarter of South Asian patients had done this compared to about half of white patients, as you can see in this graph. Similarly, South Asian patients were less likely than white patients to have shared educational materials about living donation with others, or to have allowed others to tell people about their interest in pursuing living donation. And this indicates that there might be some specific factors which influence South Asian patients' ability or willingness to communicate and share their interest in living donation with others. Sorry, just switching slides. There you go. We also asked patients what factors were important to them when making a decision about transplant, and we found that South Asian patients were more likely than white patients to say that the pain associated with transplant surgery, concerns about being able to pay for drugs to prevent transplant rejection, and having to take a lot of medication after transplant would be very important to them in making their decision about transplant. And what this tells us is that patients may have some serious kind of practical concerns around pain and medication and kind of financial implications of transplant, which need to be examined further and addressed. We also asked patients if they thought that rich patients were more likely to get a kidney from the waiting list than poor patients, and we found that South Asian patients were more likely than white patients to say yes to that question. So while wealth doesn't factor into your position on the wait list, the fact that many patients think that's the case indicates a serious level of mistrust in the equity of the transplant system, which I think is a concern that needs to be addressed from its roots. So we also asked patients to complete a questionnaire testing their knowledge about kidney transplant. And we saw that South Asian patients were less likely than white patients to receive the highest score on this questionnaire, which is indicated in the gray bars. And they were more likely to receive the lowest score on the questionnaire, which is indicated in the yellow bars. So while this might suggest some potential differences in overall knowledge about kidney transplant, I think it's important to note that patients from all groups actually answered key knowledge questions correctly. So that kind of indicates that patients understand the key benefits of kidney transplant, but there might still be some gaps in patient education around the transplant process, and we'll have to do some more work to understand the specific support needs of patients from South Asian communities. And lastly, from the research in Ontario, we asked patients what factors were important to them when making a decision about living donation, and we found that patients from all racial and ethnic groups often said that they would feel guilty having someone donate to them, that they were worried about harming their relationship with their donor or their potential donor, and that they were concerned about the potential health problems that a living donor could have going through donation. So concerns about the potential negative effects of living donation are clearly common, and I think it'll be important for us to implement practices to comprehensively and efficiently discuss the risks of living donation with potential donors and recipients as well. So to switch gears a little bit, I'm going to kind of take the rest of the time to discuss some of the findings of the research that was conducted in British Columbia by the team there, and Dr. Gill introduced everyone there. So the team conducted research with South Asian communities in BC between January and March of this year, pre-COVID, and they conducted interviews with a variety of South Asian individuals from Vancouver-based kidney transplant clinics who had donated or received a kidney. Interviews were conducted in English or in the participants' preferred language. But since this research was only conducted with South Asians in the greater Vancouver area, we do need to note that the findings might not be applicable to individuals living in other areas of the country. Also, the team had only been able to interview individuals who had gone through the kidney transplant process and haven't yet been able to connect with community members who might not have felt comfortable donating, which might provide a different perspective on barriers to living donation. So that's just something to keep in mind as we go through this data. So we were able to engage 20 kidney transplant recipients, the majority of whom were male, and 10 living donors, the majority of whom were females, in interviews for this project. So a substantial proportion of participants were born in India, and about 30 to 40% had undergone their transplant or donation within the past year. So in analyzing the data, we found three main themes that impacted or that represented kind of factors that impacted access to living donation. And those were cultural dimensions, sociocultural systems, and clinical pathways. And I just wanted to start off talking about some of the cultural dimensions that were identified as part of this work. So viewing kidney disease as a natural and inevitable part of life was seen by some participants to prevent patients from considering living donation. And this was especially relevant amongst older participants. Younger generations were seen to be a little bit more open to learning about and considering Western approaches to health, including kidney transplant. Specifically, looking at younger women, they often shared how kidney disease was a source of shame for them, and that disclosing their disease was thought to potentially hurt their marriage prospects by family. And younger women also, or younger women specifically who were considering donating, shared how they were warned not to donate for fear of being seen as incomplete or because of potential pregnancy complications that could occur or that were thought to potentially occur as a result of donating. On the other hand, men tended to express worries that donating a kidney could affect their ability to work and provide for their family. So that was an important consideration. When looking at the theme of sociocultural systems, a really big, finding that came out is around the secrecy surrounding disease, and the fact that that was actually a very common sentiment. So participants shared how they felt the need to hide health issues in order to be able to meet South Asian societal expectations. And secrecy was sometimes related to a feeling of shame that was associated with the disease, which limited patients from discussing their disease with others or seeking support. And some recipients shared how they found it difficult to ask distant friends or family members to consider donating because of the stigma and guilt, as well as concerns about donation negatively affecting the donor, which is something that we also found in the Ontario context. And participants also shared how a lack of awareness around kidney donation and the short and long-term impacts was something that they felt led to fear around the topic in the community. And some participants felt that there were common misconceptions within the community, especially the fear that kidney donation would lead to permanent health complications for the donor. So moving on to the last theme around clinical pathways, participants expressed the need to more clearly communicate information about kidney transplant and donation within the clinical pathway, and specifically around the topics of the long-term health effects of donation, the side effects of transplant medication, and expectations after donating or receiving a kidney. Participants also shared how there is a need to provide more support and more understandable information donation for kidney patients, especially non-English speaking patients who experience language barriers, as was common. And recipients also tended to note that the testing process was felt to be long and inefficient, although it was important to conduct thorough testing, but there was a clear need to streamline the testing process. So overall, I think that this research gives a really important first glimpse at some of the barriers that South Asian patients may be facing in accessing living donation, both in the Ontario and British Columbia context, but there is still a lot more work to be done around this. So going forward, we will be continuing to partner with community organizations to conduct focus groups and interviews with South Asian patients, families, and community members to gain a deeper understanding of the barriers that communities face in accessing living donation and analyzing that data, so that we can have a better understanding of the root causes of these barriers, and then be able to partner with patients and communities to determine the best ways to address those barriers, and then hopefully test those strategies to reduce and eventually remove barriers to living donation for patients from the South Asian communities across Canada. So I hope that by working in collaboration with patients and communities, we can work to make effective and appropriate and sustainable changes to make sure that individuals from South Asian communities and other racialized communities have equitable access to living donation. And I guess I'll end there. Just wanted to thank everybody for listening in today and joining the Living Donation Week events. And yeah, that's it from me.
Thanks very much, Nora. That was a terrific presentation. A lot of really interesting and very fascinating data. I'm sure lots of people will be having questions for you and for Dr. Gill about what you've just presented. So just a reminder to everyone that we will be waiting till the end of the session for questions, but please do submit them on slido.com. Again, it's hashtag AM1B to submit your questions on Slido, and we'll have the opportunity to pose them to the panel at the end. So now we'll be moving forward with hearing another patient story. And this time we'll be hearing from Fadia Jerome Smith. And Fadia received a kidney transplant. Her story is recorded as well, but she is going to be available for Q&A as well. So, moving on now to Fadia's story.
Hello, my name is Fadia, and I am a kidney transplant recipient. Here's a little bit of my story. So in 2008, I want to say that's when all the alarms went off for me. I had really severe back pains. I'd like to say severe, but because I'm an athlete and I played lots of sports and I have a lot of energy, I thought, let me just take Advil and go to sleep, take a nap. I do that and I wake up worse. So I go to the hospital and we do ultrasounds, we do all the tests, blood work and so on and so forth to tell me now that I have really small kidneys and I have high blood pressure. So then starts my internet search, and that's when I really start kind of getting interested in finding out, okay, well, how is my body getting to this point? And I never really thought that something was wrong with me. And then I started looking back, and I did have signs. Vertigo was one of the signs that I had when I was in my undergrad, that I did speak to, a doctor about, and kind of just drink water, go to sleep, you'll be fine type of thing. I had really bad migraines in high school. Same type of situation, not really giving much reassurance that everything was okay. But because they brushed it off, I brushed it off. So now fast forward to the time when I was referred to a nephrologist after all these new discoveries about my body. The nephrologist that I had in my hometown did not, to put it plainly, did not take me seriously, if I can put it that way. I'm a young Black professional. I'm, well-spoken, and I don't want to say that's the reason why he didn't take me seriously, but maybe the signs weren't, as alarming to him. He just kind of gave me some blood pressure medication and just sent me on my way. I did not feel cared for at that point. And again, if the doctor doesn't seem alarmed, then I'm not going to be alarmed. So 2008 now, 2009, I just kind of brush it off. I'm just like, I'll be okay. I get married. I have my first child in 2010. 2010. That's when, the doctors were like, why are you high risk? You shouldn't be high risk. And how come no one told you that you would be in a high risk situation if you fell pregnant? I'm like, well, the last doctor didn't care, so I just assumed that I was okay. We unfortunately lose the baby at that time in 2010, and then we try again for another child. My beautiful son was born in 2012, and then my kidney said, no mas, no more. We don't want to work anymore. You need to figure something out, body. So then my prenatal team referred me to another nephrologist, and she was a godsend. And she was the one who was literally on me every day to make sure that I was doing my blood work, that I was watching what I was eating. The nutritionist that I had at that point as well took the time to really look at my diet and what I could change to, make myself feel better, and so on and so forth. Now, fast forward to when they told me I had to start dialysis. It was a couple months or a couple weeks, I want to say, after I discovered that I had focal segmental glomerulosclerosis. I memorized that. And at that point, trying to figure out, okay, do I want to do dialysis at the hospital or do I want to do dialysis at home? That's the only time that I had a person look like me. And I'm saying all of this to say that representation is not just important in the workforce, knowing that, oh, okay, well, we have a South Asian person, or we have an African American person, or we have a Caribbean person, or an African person, or someone from the LGBTQ community. It's not just having those token people there, but it's for the patients, right? It's for the guests that come in looking for reassurance, looking for support and help. So on that journey, having someone that looked like me at that point made me feel like, okay, here's someone that I can literally let my hair loose and just be completely 100% frank without having to change my language or change the lingo that I use, not knowing what background she was. And mind you, I'm French Canadian. My parents are Haitian. There's not a lot of Haitians. The Haitian community in the GTA is not that large. So having another face that looked like me made me feel like, okay, this is someone that I can be 100% with. I can be 100% myself. And it's sad that it was at that time that I had that face. However, I'm so very thankful that, even the nephrologist that I was referred to after pregnancy, I'm very thankful that she was thorough, right? And the entire team was there to support me through email and phone calls. So I'm saying all this to say that this conversation and the research and the data that you've all worked really hard towards is to continue raising awareness in those communities, to make sure to let them know that, their concerns and their worries are not falling on deaf ears, and that their experiences matter. And, thankfully, my experience was not overly bad, but I'm speaking on behalf of those that may have had bad negative experiences in the healthcare system. So thank you very much for hearing my story. If you have any questions, I'll be right there to answer them and go from there. Thank you.
Thank you, Fredia, for sharing your story. It's really powerful to hear patient stories and really to hear what you have to say. what we also are going to do today is be able to hear from your sister, Winnie, who is a living kidney donor. And so I'll turn it over to Winnie to be able to share her story.
Hello? Can everybody see me and hear me?
Hi, Winnie. Yes, we can.
Okay, awesome. Okay, so just plainly, I guess the story for me really just starts when I found out my sister is sick. You never really plan for these kinds of things. So when I heard of how severe it was, and at the same time, had the verbal concerns of my parents and my family, like my other extended family, my in-laws, tell me that it wasn't a good idea because at that time I had not yet had my child, my son. I just kind of had to quickly just put things into perspective, which for me that meant seeing, like that the sentiment, like what sentiment kind of resonated with me and that was being repeated was that I was doing something great for my sister. And really and truly, not to knock anything to her because I love my sister, obviously. But yes, I was doing it for her, but in part I was really doing it, as she mentioned, for her son. There was no way I was going to let this little guy grow up without a mom because it seemed like that's where things were going for her. Seeing her going through dialysis and so on and so forth was heartbreaking. And she was working full time at the time. And so continuing on to doing dialysis and working and then coming home to a toddler who's full of energy but can't play with his mommy because mommy is sick. That's kind of what put things into perspective for me. So I went through all the necessary steps in order to see if I was indeed the right match, and all of that through in the midst of having my own preemie. I had a son who was premature, and so once he was born and he was stable and he was home and we were able to participate in the paired exchange program. Um, like that's when the ball kind of started rolling. So in the midst of this of all of this and trying to find out if I was a match, we were hopeful and excited until I wasn't. And so really and truly, thank goodness for the paired exchange program, which allowed us to find a match. And also thank goodness for very inquisitive hubbies, who was there asking all of the possible questions, as it seems like there is a little bit of mistrust between the Caribbean community and healthcare professionals. It seems like there's often an overload of information, but it's not always the clearest. um, the way it's communicated is not always in the clearest ways, simply because there are roadblocks when it comes to language and access to programs such as the paired exchange program. And perhaps this is what this panel is trying to change in doing the research and bringing awareness to living donors. Um, Afterwards, I would say I was often asked as well if I suffered from any kind of depression after the surgery, as the attention kind of quickly shifted to Fadia's recovery. But I always made jokes and said that I mostly felt like an imposter. I mostly suffered from the imposter syndrome, as people kind of looked at me as this hero. And really and truly, I just wanted to help my sister. I just wanted to have her be healthy and be able to have her be there for her son. So all in all, my overall experience with the medical team, was great. I don't have anything to complain about. I was never left wondering what would happen to me or what could happen to me, during the surgery or post-surgery. And again, very grateful for a very talkative husband who thinks of literally all the questions in the world as I was kind of mentally preparing to just have the surgery. And so the only real advice or thing that comes top of mind for me to any potential living donor is to trust that, and I know this sounds corny, and this is the blood donor slogan, I guess, like this gift is in you to give. It's something that you have in your body that you're able to give to someone with no, from my personal experience, with no real repercussions after the surgery. And so why not give that gift to someone who's in need? And also being able to be a living example of what modern medicine can accomplish in itself just reaffirms all of this important work that you guys are doing. So that's my side of things.
Thanks, Winnie, so much for sharing that. I think one of the things that comes out in your story, as well as Rima spoke about this, is how important the people around you who were supporting you were to you. You mentioned it, Rima also mentioned it in her video as donors, and I think that's something that that we'll hopefully be able to talk about in the question period, and something that I know that that some of the objectives of the research going on is looking at is building support around donors. And so I think based on what you said, that's clearly a very important factor. We're going to hear now from two more speakers to discuss more work that's going on within the Action Project. First, Lydia Joy Marshall, and then secondly, Dr. Ishran Muchi. It's my pleasure to introduce Lydia Joy Marshall as our next speaker. Lydia Joy is a research assistant Lydia Joy is a research assistant and a community liaison within the Kidney Health Education and Research Group at UHN. She also has many other roles. She's a tissue coordinator and team lead at Trillium Gift of Life, and she also serves as the vice president of the Black Health Alliance, which is a non-for-profit organization that strives to reduce health disparities in Canada's marginalized populations. So we're looking very forward to hearing Lydia Joy's point of view in terms of speaking of barriers and strategies to improve access to ACB communities in Canada. Lydia Joy?
Good morning. Good morning, everybody. With that introduction, I thought I would be very authentic today, since I'm speaking from the African Caribbean Black community, that I would be in the Caribbean. So I'm greeting you this morning from sunny Barbados, or this afternoon. I've lost track of time. I first just wanted to thank everybody for coming, this morning to speak about this important topic. And we've been doing a lot of work in this, and it's very timely. So I just thought I would disclose, although all these hats have been put forward of where I'm sitting, I'm not sitting here representing any other group other than hopefully my community and putting forward the voices. I think that that's already been done quite well. I don't know how much I can add from that right now, but Fadia and Winnie have really kind of set the tone of what I'm trying to amplify and the voice that we're speaking from. So I'm one person that's representing and trying to amplify some more of those stories that we have already seen and addressed at the beginning of this action project. So whenever I'm speaking, we always like to speak from knowing who are we talking about. So similar to, as Nora said, the Black community in Canada is very diverse. So we're not speaking about one community, one group. We're speaking about a conglomerate of many different communities. So our last census in Canada reported about 3.5% of the population self-identify as Black. But what that means are very many different things to different people. Some people are generational Black Canadian, some are immigrants, some are born here and associate as another culture or ethnicity. This is just kind of a very high-level overview of the majority of where everybody identifies from. Some are continental Africans, some are Caribbean, some are from various places within Canada. So when we use the terms such as ACB or Black community, it's definitely not speaking from one perspective, and we cannot capture all. We are trying to pull forward the shared experiences. And unfortunately, in the work that we're speaking about, some of the shared experiences happen to be, the disproportionate way in which that we're seeing living organ donation. So, when we use this term identity or ethnicity, it's very varied. I want to, throughout this, kind of, again, amplify the voices of those who we've been speaking with. And we found that these quotes that were from some of our participants in the study kind of emulates what people said. So they said, what does ethnic identity mean to them? It is not only how we see ourselves, but it's also affected by how others see us. And I thought that was a very important way to frame what we're speaking about today. So all of these labels that we use, we can have our own identities, we can see what we are proud of and who we are, but how others perceive us has an impact on the care that we receive and how we move through the world. Another one of our community members in the study also said it's a part of his politics, it's a present part of his life and the way he thinks and the way that he moves. And I thought that was a beautiful way of kind of capturing what does this mean when we talk about these labels of who is Black, who is part of this community, and how it impacts this work. So why are we doing this? There are so many things that I think need to be addressed. It's been quite a journey working on this action project specifically. We started this project last year, and it was just before, what is being called the COVID-19 pandemic. And since then, there has been so much unrest, both in medical community, both in social justice. And I think it's something that, we need to address. So this work has impacted disproportionately members of the Black community, both from a social aspect, from a healthcare aspect. Dr. Purnell spoke about it so eloquently this morning of, that was just one example of the crisis we have already been in. It's one example of the disparities that have been exacerbated, and our work that doesn't change from that. So when we're looking at transplantation, and we're looking at living donor kidney transplantation, the disparities exist here in an alarming rate. So we see 50 to 70% less likely chance of people from these communities and from our community receiving or giving within this. And so it's something that I believe is alarming, and it's why we're speaking about it today, and we're speaking about the contributing factors to that. So, a few of our speakers this morning, we've as we've said, there's no one magic bullet, there's no one answer. I think all of what we're speaking about together are social determinants of health. And unfortunately, all of these things are things in which members of the Black community have seen a disparity that is much different than those of their counterparts. So these are what's listed from Health Canada of what we consider as social determinants of health. I put up this list because I wanted to really also mention that one of the things through Black Health Alliance and some of our other community groups that we really advocated for was having race and racism added as a social determinant of health, and that has just happened recently. And it's something that we need to speak about. Right now, while we've been at home, everybody's speaking about social justice. Everyone has been watching the way Black bodies have been treated in the media, what's happening. Everybody's been in this state, but it's something that has existed and has been systemic in Canada and otherwise for a long time. And so the fact that our government and those are recognizing it, and it's part of the social determinants when we're looking at why do these disparities exist? Yes, there are comorbidities. Yes, there are cultural beliefs. Yes, there are biological reasons that we're seeing higher rates of certain comorbidities or even these diseases in certain cultures. But the reality is all of those things are intertwined with, how are we expressed and how are we treated and how do we navigate the system? And so we have to take a look at all of these things of why we're seeing such a great disparity. Sometimes it's easy to say, why are we seeing a different rate? Is it just cultural? We spoke about it before. We like to say cultural, then say this is not a modifiable thing. But the reality is there are ways in which we can change our comfort levels. We can change how we interact with the system. So those are some of the things that I want to highlight from our study today. And I don't want to speak just from my words. So again, to bring forward some of those who participated in our qualitative analysis, some of the voices and the words that they said helps kind of frame what it is that our community feels are the barriers to access and to transplantation. So one of the first things that I think everybody has touched on is the idea of trust. And this trust is founded in very systemic problems of how people feel that Black bodies are treated going through the system. We've heard examples of multiple times of when experiments were done without consent. We've heard times of when we were looked at as what the test is as opposed to actually trying to treat. And I think this is intergenerationally within our communities that we think, this is not for us. This was not made for us. This is not for our intentions. This was resonated often within our community members said that whether it is based in, current day fact or it's residual, it's something that has to be acknowledged and understood that these bridges of trust need to be remade. I think I really appreciated what Winnie was saying about her pushy husband. This is something that we heard over and over and over, that many people in our community feel that their advocacy and their questioning and speaking up for themselves had to be a little bit harder, a little bit stronger than what they felt from their other counterparts in order to be heard and to be addressed. It's felt that if we don't ask those questions, you won't be taken as seriously. It won't be perceived as your problems are as deep, or that the problems that do occur maybe are something that can't be changed. And so it's always felt that, like, if you don't speak up for yourself, who will? Or that the system is not intended to look out for our best interests. So this was a theme that was, I would say, the most prevalent theme when we were speaking in community of what are some of the barriers or the reasons why we see such a difference in either who's donating, who's able to receive living donations. And this was the one thing that is very prevalent. The next conversation that came up often were the modes of communication. So whether that's communication intraculturally, how we speak to one another about donation, or whether this is how we are spoken to when we're within the healthcare system. So, one of the quotes that one of our community members said is that there's work within the medical institution to ensure that when I go to the hospital to offer that kidney donation, the doctor meets me, that they treat me like a human being and look me in the eye. So often people felt that, the information in a way that we felt related to or felt cared for, or that depending on where you were entering the system, you would actually receive the same amount of care. And so, that's the way in which this information is communicated, and acknowledging oftentimes this phrase culturally appropriate communication or care is used, but what does that actually mean? And what does that mean when we're speaking within Black Canadian context? How do we receive information? Also looking at these other factors of trust and social determinant of health and all of these things together, what do modes of communication look like in that context? And likewise, within the community, we have to look at how do we speak about these things. There's an idea of, there's a sense of pride, similar to what Nora spoke about in the South Asian community, of there's certain topics that are not up for public discussion. How do we share them? How do we speak about this? And some of the foundation of looking at how to receive a living organ donation is based on sharing your personal health information. So it's something that we have to look at, incorporate into the modes of communication of how does this increase how we speak about this and how we're able to connect around this conversation. One of the other very large themes that came out, and again, the sisters spoke to this morning, I feel like they could have done my talk for me, is talking about the idea of representation, and representation at every level. So, we're having this conversation today. We're ensuring that those who are being treated, those from different communities are speaking, but this really matters to those who are going through the system. So whether it's that those who are doing the research, whether the healthcare workers, whether it's when we are communicating and speaking about how do you access care, ensuring that there are people at every level that look like the person being treated, that we represent those who we are caring for. And this doesn't only include language, although that is very important and something that's often excluded. It's language, it's more subtle ways of communicating, it's understanding culture, it's understanding concerns. Just having somebody there who looks like you, that you can feel more comfortable, that when you're expressing your story, that when you are going through these ideas of trust and not feeling judged are addressed by having those who look like you who are present. So both of these quotations from some of our community members spoke to this, I think, in a very real and present way. The first one was actually from a healthcare professional from our community that said, when they started working in this field, it was very evident that she brought a lot of hope to the Black community. It was almost like they were saying, finally, somebody who knows me and understands me is here to take care of me. It can be a huge burden. And I think that they look at me, that this trust that comes, and also an expectation, but at the same time, when I hear their stories, I feel obligated to bring a change. And likewise, on the other side, community members validated that, saying that, when you have doctors who don't look like us or who are practitioners, and they challenge them that they're not going to go beyond and up above for what we need for our care. And so this was something that we heard, across generation, across whether people were born here, different geographic areas, that it matters. It matters whether you feel that this is a representation of yourself and you feel comfortable, and that the way in which we express ourselves can be heard and understood. So I think, the other parts, some of those are institutional, some of those are things, again, that we can modify, that we can increase the conversation, that will happen over time. One of the other themes that we heard was an internal conversation from many of our diverse communities about how do we feel about donation? There's some people who are saying, do we really feel that this is, the appropriate approach? And how do we maybe change that conversation because we don't speak about it? So it's kind of like that same idea of not speaking about our personal health has allowed certain cultural narratives to grow and to say, is this good? Is this bad? What will happen to me? And we have to open up that dialogue so that we understand and are able to better advocate for our health, rooted in fact, that also is congruent with what cultural beliefs are. So it's very interesting that, we spoke with maybe 80 or 90 different members of community, and almost in every group, at least one person said, when you go down with it. And what they were saying was, when what you come into this world with, you leave with. And so it was interesting in us trying to, when we speak about community education and increasing that, it's, we have to be aware of, but how is this seen and how do we respect these type of beliefs, but at the same time ensure that we're getting the best treatment. And there's other people that also said, when it's time to go, it's time to go. And they feel like it could be either a spiritual thing or a religious thing. And that this level of intervention or medical intervention, it seems too much. It seems like maybe enough is enough. So, again, we're listening. This part of our project in the Action Project, we were sitting to listen to others to see, well, let's understand how people feel and see and feel about donation. It's not that right away we're trying to say, let's change what they think and let's change what they feel. But if we understand it, we can make sure to empower people with knowledge that is within that system so that when they make a decision, it is rooted both in all the facts, and we understand that we can encourage conversations within community that are appropriate and respectful, that they can understand and increase that knowledge base. Oops, sorry. So, often, we talk about these problems or these barriers, but it's important to say what can be done, what can we do, what is modifiable. And I think, this is to reiterate a lot of what has come before, but the top things that have come out of our work so far, and from just speaking with community on a broader lens, is we first have to acknowledge the systemic racism that exists even within our field, within, living donor kidney transplant, and within organ donation on a whole. There are areas that are very susceptible to racism. There's areas that were set up in a way that the way we ask questions, the way we interact, they might seem very inert to other people, but they are triggering, and they cause a way in which feel like you're being judged, or people from communities. I know definitely within the Black community, we've spoken often about questions that are about social status, questions that are asking about support, questions when we talk about how do people comply to this information, they seem like standardized medical information, but actually they have other rooted implications that we need to look at and say, the way in which we ask these questions, the way in which we stream people donation, could people from certain cultures that have certain beliefs or be excluded because it doesn't fit into this box of what is considered normal or what is the majority? And so we need to really sit down and acknowledge that it has not been inclusive for everybody. It has not been equitable. The markers that we use to say who is worthy of getting donation or how we educate others, it has not been accessible to everyone. And it's something that we have to start there in acknowledging that. And going in from that point and saying, how can we be accountable that we change those things that we are aware of, that we are aware within the system that can be changed? So in doing so, one of the things that was requested from a lot of our participants, from our healthcare professionals, were that we as the practitioners, as the researchers, we have to evaluate ourselves. We have to look at and say, reflect and say, well, where do I contribute to these systems of inequality, and how can we change? So then once we have done that, we need to, as we keep speaking about over and over, have representation from community. We can, as much as we want, we can educate ourselves, we can change the system, but then we need to create a safe and inclusive environment that reflects those who are being served. So whether we're speaking about the Black community or we're speaking about other communities, whatever community that is being served, there should be representation from that community at every level to ensure that this is not an academic exercise of thinking of equity, but it is something that is included with lived experience. And I think once those things are done, then we need to have community-led and partnered programs that then information can be disseminated in a way that is understood, that is received, that is appropriate, so that we can have people make informed decisions about how we share this information, how we prevent having to be on the list to begin with. But if you are there at that point, how do you share this information and allow this to be a normal conversation? How do we change those narratives within the community so that this is not seen as something that is not accessible, that is not healthy for our community? How do we change that we can say, yes, there is a pathway and we are being included and we have been thought of, and the things that we are worried about in terms of racism or we're worried about of being treated differentially has been addressed, and it's an open conversation. And whenever I say all of these things, it has to keep being repeated. It's not a one-time linear thing. It's we have to do all of this and come back around again and continue to evaluate. So, again, I think this echoes a lot of what everybody has said already this morning. And again, when I'm speaking about this is timely, I think it's important that we keep this in the context that we know there's a lot of civil unrest. Anti-Black racism in our community, not just in healthcare, is prevalent right now. I shouldn't say it's prevalent right now. It's prevalent being discussed and visible right now. And it's something that we are not exempt from that in the work that we're doing. And this quote, I just wanted to kind of end on this that I think was relevant, although it's not speaking about living donation. This is a sister of Jacob Late, was just speaking about what does it mean for her for change. We continuously are having conversations that are looking at disparities, that are looking at racism, that are looking at atrocities that we are all uncomfortable with. So what does change look like other than having these conversations? And so she was speaking about the situation specifically with her brother, but I think it's relevant in how do we address change within what we're looking at? And she said so many people have reached out to her saying that they're sorry this has been happening to her family. Well, don't be sorry, because this has been happening to my family for a long time, longer than I can account for. It happened to Emmett Till. Emmett Till is my family. It happened to Philando, Mike Brown, and Sandra. I don't want your pity. I want change. And I think, I'd like to leave us on that note saying that, we're sitting and we're speaking about what can we do and what is happening. And I think that's what we need to do.
mainly focus on some of the steps that we're planning to do, really building on many of the things that had been said already by patients and by the presenters. So I will probably skip some of the slides that will be shown here. And let's see, how can I? Okay, so to start with, and again, this reflects to some of what Lydia Joy just mentioned. I think we need to reflect on who we are, what we are doing, and why we are doing, and how we are doing. So in talking about racial equity and access to health, I need to acknowledge that I don't have a lived experience of that. I'm a white middle-aged man who has a lot of frequently unacknowledged privilege. Also, it's important to acknowledge that I'm a nephrologist and a transplant nephrologist in that. And so I do probably have some kind of bias in the way I understand kidney health and the role of transplant in that. And finally, I want to say that the data analysis and the collection in action project is still in progress. And some of these results that I will be showing, we have not been fully discussed or completely analyzed. So I guess this slide is not related to the action project, but it hasn't been stated this clearly today yet, and I think it is important to emphasize that really this is the professional point of view where I'm coming from to this point. This is based on American data from many years ago, summarizing the potential advantages of a living donor transplant and kidney transplant compared to dialysis. Orange is the bar that a young person of 30, 40 years of age would have to live if they had a living donor transplant immediately at the time of kidney failure diagnosis, as opposed to staying on dialysis. The difference between living donor transplant and staying on dialysis for a young individual could be more than 20 years. Deceased donor transplant is somewhere in the middle. And this is why we try to emphasize that from a medical perspective, living donor transplant is the best treatment for kidney failure. The lower panel shows that if you have to be on dialysis for years before you get a transplant, even if it's a living donor transplant, the advantages offered early on, some of it is gone. Still, living donor transplant is the best, but the amount of benefit that you can gain may be less. This slide was shown. This is one of our studies indicating that compared to white patients on the top, patients from racialized communities, whether that's East or South Asian or Black communities, they have much less, 50 to 70% less chance to get a living donor transplant. And this is the overall plan in the action project. And just want to emphasize that in addition to understanding these barriers that were discussed already, we try to take the first steps towards action, both trying to inform healthcare professionals about cultural competency and safety in the broad professional community, and also implement some changes in the clinical practice. This is based on our existing research, and just summarize, this is a mixed method study within the action project where we build on qualitative research that Lydia Joy summarized, and also the BC part has been mentioned by Noor as well. And in the quantitative study, Dr. Gill and his group is doing epidemiology analysis for a large scale data, and we are collecting data from patients and donors and transplant recipients to understand their attitude and knowledge. Of course, as mentioned, non-English speaking patients were excluded, and some limitations to the data collection also need to be acknowledged, that this is not a representative sample. To date, we have more than 500 patients, out of whom about 150 were self-identified African, Caribbean, or Black. And as mentioned before by Dr. Purnell and other speakers, this group, the ACB communities, have more difficulties with the socioeconomic or social determinants of health, both in education, financial deprivation, and a larger proportion of ACB patients were immigrants, which another intersection of determinant of health. This slides kind of conflicts some of the issued around being able to have a living donor identified, and this is Black and other groups who have no living donor identified at the time of assessment, compared to white patients. All the racialized communities had much less chance to have a living donor identified, whereas there was no difference. Everybody would say that if there was a donor, if there was an offer, they would accept it. So this is important because, as mentioned by Noor as well, that really most of the patients whom we asked, regardless of race or ethnicity, they understood that transplant was a better treatment in terms of survival or quality of life. But still, many of the patients who were coming from racialized communities, they were not able to explore the options. They were not able to have a potential donor. So this is a very stark contrast that they would be able to and willing to accept the transplant. They know it would be better, but for various reasons, they are not able to explore that. And this is, again, something that Noor showed already, pointing to the Black patients here compared to the white patients. Black patients, but other racialized patients as well, were much less likely to have talked to others about their need for transplant or even sharing educational materials. This speaks to the fact that was discussed before, that in the ACB communities, talking about health and illness is not something that is easily done. And of course, this is not necessarily unique for ACB communities, but clearly this is something that we need to address in our work. Lydia Joy mentioned about the trust issues, which are fundamental. Representation, that we need people who look like the patients in order to have that trust. And this graph illustrates the complexity of these issues where we are. And I just wanted to show this to emphasize that race here in the structure of basic social, economic causes of ill health at the other end here. We try to improve health, but we do need to, under the fundamental foundations, the socioeconomic determinants of health, of which this racialized status is one. And there are many intervening factors that will determine health outcomes. So what can we do here? As I said, we will try to make available for the nephrology professional community culture, competency, information, and training programs. But importantly, we try to work with community partners to co-develop education and clinical pathways about transplantation. And so we try to kind of create this patient-centered, culturally safe kidney space, which is kind of indicated with the blue here in the center, where we work with community health centers that serve mainly or exclusively Black patients. Also, we try to partner with the community organizations like Black Health Alliance and provide the professional support from the transplant program and the renal programs to create a space where patients would be able to meet with other patients or with professionals who are from their community. And we would support those pathways with the highly specialized transplant or nephrology knowledge or tools, but building on both prevention of chronic kidney disease and the best treatments for that. And as I said, we would do that in partnership with many community organizations. The Taibu Community Health Center is one, and Black Health Alliance has been instrumental in moving the project as we are. And we do have additional partners from within the community, hopefully enabling us to achieve what we did. And at the end, I just wanted to acknowledge that the Toronto arm of the Action Project has been working hard. Noor, Beth Edwards, who is one of our qualitative researchers, Lydia Joy, and Paula Neves, who are helping this project to continue. And this is some of our team members who have been helping with the data collection. Thank you very much for the attention.
Thank you very much, Ishvan. That was a terrific overview. Before we move on to the question period, I just want to give a few moments to Dr. Humar to make a few comments about today's session, and then we'll be moving on to questions. So please do submit them on Slido if you have any burning questions. Dr. Humar?
Yeah, thank you, Sunita. I'm just going to turn up my volume here. So I think I'll be brief. I just thought the talks were just amazing, and I think our patient partners especially spoke very eloquently, and it was very moving to hear that. So I think we all realize, but it's worth stating that we as a transplant program and transplant physicians and surgeons take issues of equity and racial disparities in access to transplant very seriously, and I think, in fact, that's true for all programs across the country. But I think we all realize that we can do better, and we have to do better, and we are very open to all the patients who are on this presentation right now, and all the patients out there, and all the community folks out there. We are very open to all the feedback and suggestions you give that will allow us to do better in this area. So thank you very much. And with that, I'll turn it over to you, Sunita, to guide the questions.
Thanks very much, Atul. I'll just want to echo Dr. Humar mentioned how important it is to kind of hear from our patients. It is very, very powerful, and I definitely feel like there's a lot of value to hearing what you have to say. And to that end, I'd like to pose some of the questions that's come in on Slido. I'd like to pose some of these questions to our patients. There are a lot of them that are coming to you and to get your thoughts. And so the first one, to the patients, if you can suggest one thing to improve the experience of exploring living donor kidney transplantation for future patients, what would that be? I don't know if Winnie, Rima, or if, oh, sorry.
Is this is anyone's game?
Anyone's game.
All right, so I think for me, and this is something that my sister and I were kind of talking about briefly after we had kind of a little bit of a debrief about what the section today was going to be about, is that, and I don't know how to say this without sounding maybe condescending, but it's interesting that when you come into this kind of a situation, the professionals, you guys know what you're talking about, but we may not necessarily understand all of the jargon and the medical terms and things like that. And so when I was talking about earlier about the overload of information sometimes, and kind of having somebody there to advocate for you and to kind of ask for clarification on certain things, I think that would be one of the first advice that I would give, like one of the things to make sure to have put in place, so that it would drastically improve the overall experience between patient and doctor, or patient and medical team, and even like between patient and their family members, so that when they go back to relay information about their condition or about the procedures, that it's being given perhaps maybe in layman's terms, so that everybody kind of is on the same page and has access to the same information, has an understanding of all that information. Because as much as I like to watch House and Grey's Anatomy, there's only so much that's gonna bring me in terms of my knowledge of medical terms. And so listening to the doctors earlier, which have fascinating data and things like that, unfortunately, most of that goes right over my head, which is something that I did, like I said, if it wasn't for my husband kind of pushing to ask the questions and for clarifications, would have kept going over my head, and I would have had clarification on. And so perhaps that might be one of the things I may suggest.
Thanks very much. Any other of our patient partners who want to chime in?
Yeah, it's Rima here. So of course I had donated my kidney here in British Columbia, although the care was fantastic. I think if I were to reflect afterwards, I felt a bit of almost like, it was that same sort of, even though everything went successful, I did feel a bit of lack of, it was almost like a bit of it was a weird roller coaster ride. So I think just a little bit more attention and care post transplant, more so when we got home, I think would be very beneficial. Oftentimes I was feeling a bit, I didn't know what to feel. And so I think the post care once we got home, I think if that could be a little bit more, little bit attention put on the donor, I think that would have helped my situation out a little bit more, now looking back.
That's a really interesting comment, Rima. I think one of the things that you mentioned about post-care, and in my mind, this may tie into a little bit of the fear. There's a little bit of the fear factor of potentially of donating because you don't know what to expect. Do you feel like kind of if you had a more cogent post-donation plan, or kind of something more comprehensive post-donation that would have potentially, or do you feel that that's something that potentially could alleviate some of the fears that are being felt in certain communities about donating?
Yeah, exactly. That could be it. It's hard to describe what I was feeling. I think you're right. I think it probably would have. I think it was probably a bit of fear, or fear of next steps, or all of those things, and maybe even just checking in fear of how the kidney was doing within my sister's body as well. So there was just a lot of heightened emotion at that time, now that I think back, and yeah, a little bit more attention to that, I think would have been great.
We have a question on Slido that I'd like to pose to the research team, and something that potentially you may have found in your preliminary results. One of the questions is, do money or finances play a role? Many people can't take time off work or think that it will cost them money to donate. Is this the case? So just some questions around the economics. I'll open it up to the researchers.
Sure, I can start to address that. So I think in the context of what we're looking at right now, that theme hasn't emerged as a massive as a massive area yet. But I think there's enough of a body of literature that exists prior to this, right? That we know that income matters. We know that financial barriers are a real thing. One of the challenges, as you know, when we look at that data and say, how do you fix that, has been there are programs to certainly supplement some of those things. And there's wage reimbursement and all that kind of stuff that we're trying to move forward on and do more in a more fulsome manner. I think my personal experience has been is that it's kind of like what Rima described, right? The issues in the process that are flawed. It's hard to determine to what extent that deters people from donating, right? Because I think in my experience, the people that have come forward and donated are so committed that they often will go ahead and do it anyways, despite some of the flaws in the system. And so, so it becomes a bit of a philosophical discussion to say, do financial barriers exist? Absolutely. Should we address them? 100%. Will addressing them increase living donation? I'm not sure. But that doesn't mean we don't address them. And that's kind of the ethos, I think, of the project as well, in terms of, when we're measuring the impact of some of this work, are we going to say that it has to increase living donation necessarily? I don't think so. I think the output here is to make sure that we have a process that's going to be a better system, that's going to support people better. And the hope is that by doing that, you will create a culture of trust and a system that's going to actually encourage people who maybe are on the fence of donating to at least consider it in a slightly different manner, but more importantly, for the people who are wanting to come forward, they'll feel more supported during the process. So to answer your question, yes, I think finances do play a role. To what extent it impacts people's willingness to donate, I think is still a bit of a question mark.
Thanks very much, Jag. We have another question.
Maybe,
sorry, go ahead.
On that, I think in our data set, we do ask about, or the decision balance questionnaire asks about concerns about finances. And so within our sample of 500-600 patients, we see that actually there is a significant concern, and also what had been discussed in the previous session as well by Dr. Waterman and Purnell. It seems that these concerns are not equally distributed amongst the racialized groups, and certainly ACB communities or patients from these communities seem to be a bit more concerned about some of the issues around medication costs or unknown costs, and also they are more concerned about the fairness of the system overall. So that is one thing, and also just wanted to bring back some of the data that Dr. Waterman presented earlier in the previous session, indicating that out of the 2,500 donor candidates who started the system, people who had better finances to start with, they were more likely to eventually donate. And that kind of points to the possibility that we hear anecdotally when talking to centers in Ontario as well, that centers who serve patients that are more remote and potentially less financially stable, they say that many of their recipients would not necessarily even ask or accept a donation offer because they know how much potential economic or financial burden that would place on the donors, or donors would not even consider exploring this option because they know that they cannot even afford a few weeks of being off work. So I think as you said, some people who are on the fence may be better able to explore this option. And again, I think that's what we try to do, is to enable patients to explore this option, hopefully free of any pressure, either negative or positive pressures.
Thanks very much, Dr. Mucci. I think we're a little bit over, but hopefully we have time for one more question. And one of the themes that came out in today's talk is the difficulty in sharing your personal story and sharing the need for a transplant. And so maybe a question to the panel. Lydia Joy, you touched on this in particular. There's a question about how we can balance respecting people's desire to keep their personal health information private, but also encourage people to share their story so they might be able to find a living donor. And I think that's obviously a difficult balance. People have discussed kind of the idea of having somebody champion the story for you. I'm wondering if you can share a bit more of what your research has been able to discover about this topic in general.
So it's a conversation we spoke about a lot, and I think the important thing is using channels that already exist. So we're trying to superimpose, what we've already said. We have social media campaigns, et cetera, to say, I need a donor, I'm suffering. We often like to plead to empathy in what our healthcare system uses right now, and if that's not in alignment with what some of the groups that we're working with do, then we have to see how is information shared, how is it done in a respectful way that people feel comfortable. And you're right, it might be that there's someone else championing on your behalf. It might be that there's a conversation that's had without sharing that personal information. There might be channels in which information don't feel as public. And so the conversation has been around, this goes back to if you're represented and you have channels and things already in place that are already community led and they feel like a safe space, that information can still be shared. I think right now what it feels like is like coming into this bigger institution when you're not seeing someone that's reflecting you and sharing your information there, or sharing it public, or sharing it in a broader social media, or the other things that are suggested. I think that's what is a deterrent. But if it's done and we create spaces that don't feel so othered, I think we can encourage those conversations.
Perfect. Thank you very much, Lydia Joy. Just Noor, any comments from your perspective with respect to that question about sharing personal information?
I think Lydia Joy did a really great job answering that. I don't think that I have much else to add. This has been a question that we've kind of been toying with back and forth within our team. And I think that I wonder if the patients and donors have any kind of additional comments to add to that. I'd be curious to hear their perspectives if we have time.
I think we have a few minutes left for a few final comments. Okay, well, thank you very much. So then I think if there are no further comments from our panelists, I'd like to thank everybody for being a part of today's session. I think it was really incredibly informative, and I want to thank all of those who tuned in at home who participated today, who sent in questions as well. I also want to remind you that we have other sessions for Living Organ Donation Week that include a conversation with our coordinators from the kidney transplant program this afternoon. So please do tune in to that session at 2 o'clock. You can also find the complete schedule of events on www.livingorgandonation.ca. Just want to end the session by not only thanking our panelists, our patient partners, but also we're very grateful for the generosity of our founding supporters, the Astellas Pharma Company, the Kearney and Cahill families, as well as a big thank you to the Toronto General Hospital Foundation for their continued support. So thank you very much for joining. Appreciate your participation and for all of the insightful comments and presentations. Have a great afternoon.